Everybody. My name is Chris Pearson. I am proud to be the chair of Vermont Healthcare 911 and welcome you to our first webinar ever. This one about reference-based pricing and the great potential it has for us to reduce costs in Vermont, and some of the story that has come from other states leading in their examples that we want to copy and emulate and build upon in Vermont. The Vermont Healthcare 911 is a coalition for action, a politically diverse coalition of business leaders, community leaders, healthcare practitioners, civic leaders, union leaders, coming together, united around the idea that we have to get our arms around healthcare costs and bring them down, that we are truly in an affordability crisis for healthcare here in Vermont. And to that end, we have published a lot of comparative data looking at our hospital costs, trying to understand why Vermont's healthcare premiums are the most expensive in the country and what we can do about it. So today's discussion will feature experts from around the country who have themselves been answering some of these questions and come up with some strategies that we hope will be relevant and are in fact coming to Vermont. We welcome your questions. We are going to hold questions till the end after our presentation, and we are asking people to submit questions into the chat. So if you have a question now or as the presentation comes through, please put that in the chat. I will collect those, and we will ask our panelists to give us their answers at the end. We may not have time to answer everyone's question, but we will do our best, and we may even look to record questions that we don't get to and get them out in another way. So, as we got started at Vermont Healthcare 911, we knew that we needed to have a broad and unusual coalition coming together so that the data and our story would be taken seriously by Vermonters, by the media, by our hospital regulators, by the hospitals themselves, and others. And so we set about to form a coalition. You might think of it as our advisory board. And I'm very proud to tell you that the co-chairs of the Leadership Council are here today. They are Lisa Ventris, longtime president of the Vermont Business Roundtable, and Governor Jim Douglas, a man who I expect needs very little introduction for most of you. So I will turn it first to Lisa to say a quick welcome. Lisa, the floor is yours. You may have to unmute.
Great. Thank you, Chris, and welcome everyone. It's great to see so many people on today. So 1 year ago this January, VHC 911 broke the glass and raised the alarm on Vermont's affordability and healthcare costs. And at that press conference, as Chris said, we had members of this diverse coalition together, and we heard from many business leaders and others citing the adverse impacts of high costs on their company's ability to turn a profit, invest in their facilities, hire new people. And they spoke compellingly about those challenges and about the need to rein in healthcare costs if we're really to reverse the damages that are being done to Vermont's reputation as a wonderful place to live, work, and raise a family. With the involvement of VHC 911 Leadership Council, 2025 was an impactful year, and Chris referred to our report that we've issued. So we want to thank you for helping raise public awareness and spreading the word and building momentum for change. And with events such as this webinar today, we're committed to continuing our role to bring information and resources to bear to further healthcare reform efforts. So continue bringing your voices to the table and sharing your experiences with us. So thank you all.
Thank you, Lisa. Our other co-chair, Governor Jim Douglas, I should say, to introduce myself, many of you wouldn't know, I served for 14 years in the legislature I was appointed to the House by Governor Douglas, and I was a progressive Democrat by the end, serving 6 years in the Senate. Governor Douglas vetoed several of my bills, and I have never quite forgiven him for that. But it's been great to get to know him better over this past year, and I've come to call him a friend and to find common ground united against uh, completely unsustainable healthcare costs in Vermont. So, Governor, I wonder if you could just say hello.
Well, thanks so much, Chris, and thanks for your leadership of our coalition. I have never regretted that appointment, by the way, and knew you were going to do great things decades later. So thank you for what you're doing for VHC 911 now. It's great to be working with my good friend Lisa Ventris, who has provided leadership to our business roundtable for many, many years and understands the importance of the task ahead of us to the business community in particular. I got involved in this last year because I saw where things were heading from an affordability standpoint. Everybody's talking about that now, nationally and here, but we were concerned about affordability before it was cool. And if you look at the population trend over the last year, Vermont's one of only a few states that lost population in the latest report. And we have to ask ourselves why. Who wouldn't want to live in the most beautiful place on the planet? Well, because you have to be able to afford to live here. And we've got a lot of issues that are working against that. The unavailability and high cost of housing is certainly on the agenda. We have a very high tax burden compared to other states around the country, and healthcare costs have gotten out of control with the highest premiums by far of any state in America. So I'm thrilled to be working with so many people to attack that third point to try to bring down the cost of care. And we've seen a lot of effort over the past year. Our regulators at the Green Mountain Care Board and the Department of Financial Regulation are applying appropriate scrutiny to hospitals and insurers as they come in for budget and rate reviews. The legislature has been very responsive in the past year, enacting a bill to cap the cost of a lot of drugs, which is a very important part of the cost structure of healthcare, of course. And as Chris suggested, an opportunity such as today's webinar to look at new to us approaches to try to contain the cost of care. So I'm really excited to be a part of this and also a part of this coalition because, as you intimated, Mr. Chairman, healthcare costs are not partisan. We're all facing them, whether we're individuals, families, small businesses, or taxpayers because of the public employee healthcare costs that we're all supporting. So this is critical work. I'm delighted to be involved with so many of you and look forward to our discussion today.
Well, thank you, Governor. Before we welcome our guests, I want to turn it over to one of our board members to lead the panel discussion. Mark Hage works for the NEA, the Educators Union in Vermont, and he serves on the VHI. He's the VHI administrator, which is the public health benefits program for teachers and educators. Mark, I hope I've done you justice, but he has been a champion for healthcare reform throughout his career, spanning probably over 20 years in Vermont, and a welcome part of our coalition, and well connected to the panelists today and leading the charge. Mark has been here in Vermont for reference-based pricing and well informed by his friends who he will now introduce us to. So Mark, take it away, and thank you for your leadership.
Thank you for those very kind remarks. And welcome all. It is really a pleasure to see you. We're very excited about this program. I asked Chris for the privilege of introducing our guests and leading this panel discussion because each of them has been one of my teachers when it comes to reference-based pricing, and each has contributed significantly in recent years to legislative and regulatory developments in Vermont with respect to reference-based pricing and elsewhere, as you will learn. Their guidance to state policymakers and to VHC 911 has always been grounded to credible data and research, and each has been tremendously generous with their time and their counsel, and their knowledge and research in this field are simply invaluable. VHC 911 will post on our website the presentations you're going to see and hear about today. We will also post a groundbreaking report or study that was overseen by the Green Mountain Care Board in 2024. I believe it was the first ever comprehensive reference-based pricing analysis of hospital claims, inpatient and outpatient, that had been incurred by VHI, the Vermont Education Health Initiative. As Chris said, the risk pool that provides healthcare benefits to our public school employees and their dependents, and also state employees whose benefits are provided by the state's medical fund. That report repriced the hospital claims over the years 2018 to 2023. And it showed us that if those two pools combined had reimbursed Vermont hospitals at 200% of what Medicare pays, double, in other words, we would have reduced spending for those two pools combined by $400 million for the years in question. The VHI portion of that would have been $230 million. So we're talking about a very significant reform initiative. So we'll provide access to that report as well. I'm going to introduce each of the guests right now, or say a little bit about each of them, and then we'll begin the program. And our first speaker is going to be Marilyn Bartlett. She is a special analyst now at the National Academy of State Health Policy. A decade ago, though, as a health plan administrator for the Montana State Employee Benefit Plan, 31,000 covered lives, employees and their dependents, just a little smaller than VHI. She negotiated directly reference-based pricing contracts with several acute care hospitals. This ultimately reduced costs for the state in the first 2 fiscal years alone of $47 million. Now, several states, in their own fashion and to different degrees, have followed Maryland's example since. And they include the state of Oregon, which we'll learn about today, but also states like South Carolina, North Carolina, Indiana, Colorado, Washington State, and Oklahoma. Maryland's accomplishments in Montana turned around a state program that was teetering on the brink of insolvency. She made healthcare more affordable for state employees, and eventually this led to various national collaborations. Chief among them was the development of a hospital cost tool for national, which uses Medicare cost reports to identify a hospital's financial condition and the multiple of Medicare rates that would constitute a break-even point for each facility. That hospital tool is now used by other states, employer groups, regulators, academic researchers, and yes, by VHC 911. Marilyn comes initially from an accounting background, and she describes herself as an accounting nerd. Now, that may be true, but it's also true that her reference-based pricing initiative in Montana and other accomplishments since fundamentally changed the public and regulatory conversation on hospital prices, and it has inspired countless reform advocates, regulators, lawmakers, and even union folks like me across the country. Our second speaker will be Margaret Smith-Issa. Margaret is a program development lead with the Oregon Health Authority. OHA administers 2 large public sector insurance pools with approximately 300,000 covered lives, the Public Employees Benefit Board and the Oregon Educators Benefit Board. In 2019, Oregon instituted reference-based pricing at 200% of what Medicare pays for in-network facilities and 185% for out-of-network facilities, impacting initially 24 of that state's 62 hospitals, and generated very substantial savings, which Margaret will speak to. Margaret also staffs the Innovation Work Group for the Oregon Health Authority, and since joining the Public Employees Benefit Board, she has worked in a variety of areas, including value-based benefit design, health plan quality measurement, and research and development for condition and wellness management. Prior to joining the Oregon Health Authority, Margaret worked in health analytics for a large health plan and in health research and policy at a federal government agency. Our final presenter will be Rosalind Murray. Roz is an associate professor of health services, policy, and practice at Brown University, and an analyst with a national scope with the Center for Advancing Health Policy through Research. Roz's research focuses on healthcare spending, private insurance markets, and state policies aimed at curbing commercial healthcare prices. Her work has been published widely as well, including Health Affairs and in the Journal of the American Medical Association Health Forum. Marilyn, Margaret, and Roz, thank you so much for being with us. And Ms. Bartlett, the floor is yours.
Well, thank you. I thank you, Chris, and thank you, Mark, and thank you for the kind introduction. I'm honored to be here today and to be asked to present. I'm trying to share my screen. And
You should be allowed to, Marilyn.
it's one participant can share at a time.
Okay. Did you ask? Yeah.
I don't know if somebody has share screen on.
Uh,
Multiple should.
yeah.
There, that worked great. Thank you. Can you see my screen now?
Yes.
I am sorry, folks. I am not really good at this technology, but let's give it a try. Okay. As Mark said, I was the plan administrator for the state of Montana Employee Health Group Plan. I joined it in September 2014. Oh my gosh, that's 12 years ago. And I was ready to retire. I had worked as a controller at Blue Cross Blue Shield. I'd worked as a CFO at a third-party administrator. And being a CPA, my background was accounting, and I learned to follow the money. And I was a little bit disillusioned about how healthcare is paid for. But the state of Montana recruited me. The plan was headed to bankruptcy, and they asked to turn it around fiscally. And I thought, well, that might be a good challenge. I think I'll give that a try. So I went to the state of Montana. And this is what we faced when I came in at the end of 2014. This was the actuarial projection. The plan had just come off a year of losing 28 million. It was continuing to lose money, and the projection showed that reserves would be minus 9 million by December 2017. The plan itself was with a large carrier serving as a TPA. And what the plan was doing was stacking point solutions. They were in a panic of how to save money. So they were adding different vendors, which is something you don't want to do. So we thought, how are we going to manage this? So at that time, I was really intrigued coming off of working at Blue Cross Blue Shield and working for a TPA. It really bothered me that hospital prices, provider prices were a discount off ChargeMaster because you had no control over that. Being an accountant, I always wondered, why don't we price it at cost plus, like you see most other businesses and industries do? But we were doing secret discounts off an arbitrary ChargeMaster rate, and that bothered me. So as I started talking about that, I wanted to really fully understand, because I felt price was the problem. And this is some work that had come out in 2016 later, but I had been working with the Healthcare Cost Institute while they were studying this. And as you can see from this, price is the issue. The blue line shows you what price was going up, where utilization and intensity was not really that big of an issue in the overall price. So that led me to think we have to change our reimbursement methodology. So to explain this, I went to the carrier that we had and asked for data, and they would not give me the plan data. So I used our actuary, and he was able to very simply go back and look at hospital, semi-private, board and room. That's pretty stable. And what I was trying to illustrate here is if we continue to pay a discount off ChargeMaster, the trend is going to continue going up. We have no control over this. And this was the cost per day, and you can see what the charge was than what the allowed was. We were going to continue that trend. So I had been thinking along the way about Medicare as being a cost number. And when you read the MedPAC reports, you realize that Medicare sets their IPPS, OPPS rates so that a relatively efficient hospital will at least break even. So in my mind, that becomes a cost. And to pay a multiple above that would be paying cost plus. Now, we looked at different reference points. We looked at like an average of network pricing. We looked, but that was still charge master less discount. So we landed on Medicare would be our reference point. And we felt it's a common reference. It overcomes variation in charge masters and billings practices. It's a base. It's adjusted for case mix, geography, also adjusted for wage index. The calculation process is publicly available. You can see how the rate is determined. But even more so, it would move our plan to DRG and APC reimbursement methodologies, which had proven to be effective. Now, what we decided is we wanted contracts with every hospital. We have 11 acute care hospitals in Montana and 48 critical access hospitals. But as I examined the cost of Montana hospitals, 87% was with those 11 acute care hospitals. That's where we needed to start. Now, I was stuck with Montana procurement laws, which would not allow me to directly contract with the hospital. So I had to find a third party that would do that contracting for us. We wanted no balance billing, so we needed contracting. We didn't want the standard reference-based pricing, which was set in a summary plan description, and the member would be charged for that difference. So we needed contracts. We needed quick financial results, but we also needed control over future reimbursement increases. So we knew we had a short time to get this done. We developed what our methodology would be, and it would be for all services across the board. We wouldn't exempt anything. I had seen too many times bundles that you may do a reference-based pricing bundle on musculoskeletal, but then being on the other side of the business, we would see the prices for maternity go up. So I didn't want this bouncing thing to be going on. I wanted it across the board, including infusible and hospital dispense medications. So the first thing we did was we worked with the actuarial data that we had, and we did an RFP, and of 9 responses, only 1 would do what we wanted to do, and that was Allegiance. It was a TPA in Missoula, Montana. They became a subsidiary of Cigna, but they operated under their own board. And they had been studying this type of a methodology, and so were prepared to help us. But they were the only carrier TPA that would do this for us. So in analyzing our data, this is what we found that we had paid as a multiple of Medicare. And we asked them to bring in other data that was under the same, so we could have a good statistical sample that were under the same provider contracts. And then we knew the utilization of our members in these areas, and the 611% for outpatient was a high utilization area. But what we thought is if we could set that bar around 250%, we already have 4 players in the ballpark there. Maybe we could start getting to that. The next thing we looked at was inpatient, and we set the bar there to try to get to 200% of Medicare on the inpatient. Again, we had 2 players. You'll see O at 191% and N at 224%. These 2 hospitals had very high quality ratings, and we decided those are the 2 that we're going to work with first. So we went ahead and rolled out our plan, and we negotiated with every hospital, with the TPA and with us sitting at the table. And the first thing that happened is that the Hospital Association and all the hospitals did not trust our data. They said, you're completely wrong. We only trust Cleverly and Associates. And we said, fine, we'll pay for the study. Let's give our data to Cleverly Associates and see what they say. So the light bar is what we had calculated we were paying. And Cleverly and Associates uses a health charge index, and they are the dark bar. So this refuted the argument that our data wasn't reasonable because it came up right in line with what Cleverly and Associates had. Now the line is buried over there on the other axis of where we were showing these hospitals were coming out as a multiple of Medicare. So everything lined up, and that was the first thing we did to kind of get that boiling point down and get hospitals to the table. We developed a plan that some of the hospitals that were very high needed a glide path. They needed 3 years to come down. And this is inpatient, outpatient blended. So to begin with, that spread was 271 points. And our goal was to get that spread down over 3 years by 2018, that we would have everybody within that range. And that's what we contracted for. This was another slide we used with the legislature at that time. And we were calling, at that time, we were calling it transparent pricing because we didn't want to call it reference-based pricing. That had a negative connotation in the market. CalPERS had used that term where they set the price, and if you went to a facility that was charging more, you paid the difference. And we saw the carriers and the hospitals come back against reference-based pricing and use the messaging against the plan that you're going to be burdened with all these costs, employees. So we changed it, and now transparent pricing has another name. So through this, it really was reference-based contracting. But we showed this and we said, okay, this is the actuarial trend, the dark green bar, as well as the actual. This is where we're headed if we continue with this discount off charge master pricing. Plus, through the process, we found that most all, especially with our big carrier, Montana, had revenue neutral provisions with the hospitals where they guaranteed the hospital quarterly payments. And then when claims came up, it would go against that and then settle up at the end. We wanted to get away from that. And you can see that the light blue bar is where we thought we would be and with our savings. And we did achieve this. So this is what happened. We had all these contracts in place. They came in staggered, but we went live July 1st, 2016. And you can see that big drop there. Along the way, we had cut out a lot of the point solutions. We had cut out the expensive consultant firm, a national firm. We had changed to a transparent pass-through pharmacy. So we had done some things there. But by 2017, instead of that minus 9 million, we were at 112 million to the good, and we had not raised employee premiums. The good news to me was, as you can see, the state uses a process called risk-based capital to state what the reserve level had to be. When I came into the plan in 2015, we were below required reserves. But through the efforts, you can see how we climbed way beyond what required reserves were. And this is done by the actuaries. In 2020, we wanted to see how we had done, the legislature did, and now professional comes into play here. We increased professional rates in some places to 200% of Medicare. Actually, we increased an average up to 160%. But this shows you what we were able to achieve as blended. Now, the green bar looks a little lower than I showed you in the other slides because this includes professional, where the other was inpatient, outpatient only, which was our focus. But you can see we achieved that goal. So our plan was in effect through December 2022, and it strengthened the financial foundation of the plan. We were over-reserved. In late 2017, Montana was faced with really severe forest fires, and we then had more money in our reserves than the Montana General Fund did. So the state came back to us and asked to borrow money. And of course, being the accountant I am, I said yes, and you must pay the statutory interest rate, which they did. So we continued to lend money to the state. In 2018, we did a premium holiday, allowing the state to pull back in $25 million. We did another premium holiday in 2021, allowing the state to pull back in $27 million. It was overfunded. During that time, there was no increase to members' premiums or state. We were double the plan reserves by 2022. And so we expanded benefits. We did on-patient health centers, on-site health centers. We did a lot of things for the members without raising premiums or contributions and building up reserves enough we could give money back to the state. Now, here's the sad part of my story. A new governor comes in and is determined politically to get rid of those contracts and go with Blue Cross Blue Shield Montana PPO network. So they terminated all the contracts and they went with Blue Cross Blue Shield's PPO network. But this is where I really caution you. Do not go with an aggregate measure. And I'm concerned about that because a couple of the plans you mentioned, Mark, have gone with aggregate. Our model, and you'll hear the same from Oregon, was to do it on each claim in every service. So what came into play was an aggregate that at the end of the year, Blue Cross Blue Shield, 3 months after the end of the year, would calculate what was paid as a multiple of Medicare on each. And if they averaged it, it would be 200%, or they would owe a bit of an admin premium back. Now, this really hits the member because the member is going to receive whatever the price was at the point of service before this look back period. So it could be a charge of 500% of Medicare, and their coinsurance and deductible is based on that. They're never going to be set right. So now the plan is way below required reserves and expected to become insolvent in 2026. And I wanted to show you a quick example of just 2 claims paid under the PPO contract. Claim 1 would be paid at $125. Claim 2 is a larger spend service at $27,500. So when you get to the end of the year and you look at how they were paid as a multiple of Medicare, you look at the Medicare rate. The first one was paid at 125% of Medicare, the second one 275%. But you average them and it's 200%. Under the contracts we had, it was at point of service. So yes, claim 1, we would have paid $200 on that at 200% of Medicare. Claim 2, you can see, we would have paid the $20,000 to 200% of Medicare on each claim. So overall, our plan would have paid $20,200. So you can see what happens when you do aggregate and what happened to the state of Montana in switching to that. They paid almost $7,500 more on just those 2 claims. You can have a lot of $100, $200 doctor office claims, MRI claims, X-ray claims, but offset it with some really large claims, and this is bound to happen, and that's why the plan is insolvency now in just 2 years. So I really caution you as you move forward to really flush this out. I'm seeing more and more of the carriers offer their reference-based pricing at aggregate level, and this really does worry me. So that's my story, and that's what we did. And I thank you very much for letting me tell the story.
Marilyn, thank you. No matter how many times I hear this story, it still inspires. So appreciative of you being here today.
Thank you.
Thanks. All right, we're going
Thank
to
you.
stay focused on the West. We're going to move to Oregon now. Margaret.
Hello. Thanks so much, Mark, for the introduction. It's so great to be here with this group. I'm really excited to share what we've worked on and hopefully provide information that you can take and consider in your own context and make carry forward and further develop, make even better. I do want to say it is really fitting and appropriate that Marilyn went right ahead of me, because when we pursued hospital reference pricing in Oregon back in 2017, the model she worked on in Montana was something that we really looked at as something to copy in terms of approach to take. So I am going to pull up my slides and I'll dive right in and talk about our approach and what we've done. And just making sure, let's see, can everyone see my slides? Great. Okay. So again, my name is Margaret Smith Issa. I am a program and policy lead with the Oregon Public Employees Benefit Board and the Oregon Educators Benefit Board. These are two programs that operate within the Oregon Health Authority, and they are the two state employee purchasing pools for employee health benefits. Just kind of a quick overview of what I'll cover, just a little bit about who OEB and PEB are. I'll share a little bit of context about the health benefit cost challenges. I'm sure that information will probably resonate and sound familiar. And also give kind of the background details about our hospital reference price cap, which was actually implemented through legislation back in 2017, Senate Bill 1067. I will share some information on the savings we've achieved and also just some general thoughts on the impact and considerations moving forward. So with regard to OEB and PEB, the Oregon Educators Benefit Board and the Public Employees Benefit Board are, as I mentioned, the public sector employee health benefit programs in the state of Oregon. Both are governed by joint labor management boards with board members appointed by the governor and approved by the state senate. OEB, as we like to call our educators pool, provides benefits for over 240 different school districts, education service districts, and community colleges across the state. PEB, the Public Employees Benefit Board, provides benefits for over 200 state agencies and universities within the Oregon university system. In addition, under statutory language that was passed several years back, local government entities can opt into either PEB or OEB for their employee benefits if they'd like to. Currently, about 3% of the total enrollment is represented by those local government entities. They include cities, counties. We've got a hospital district, water district, just, sort of any local government jurisdiction that meets the statutory definition of local government entity can opt in. And so together, both programs combined cover about 300,000 people. About 100,000 of that is employees, with the other 200,000 represented by family members and covered dependents. And that total 300,000 represents about 15% of Oregon's commercially insured population. So in terms of kind of the the driving factor behind all of these efforts that we've been exploring, and the ones I'll talk about today. It's health benefit cost growth, right? This is data provided by our actuary. We contract with Mercer Health and Benefits for our actuarial services. And so information based on their surveys of employer plans nationally, and this goes back all the way to 2015, has really shown over the years that in general, the annual change in health benefit costs per employee exceeds both inflation and growth in workers' earnings year after year. And you'll note the purple line is sort of the annual change in benefits cost before plan changes. And then the black line represents the actual trend after taking into account employer plan changes. And you can see both still trend in general higher than other markers of inflation. So this is the challenge we're confronting year over year. Healthcare costs, health benefit costs just grow at rates that exceed other costs. In addition, when we looked at, what are the specific drivers of health plan and health benefit costs, hospital costs for a number of years prior to 2017 had been identified as a cost driver year after year. We looked specifically at some of the larger DRG hospitals in Oregon, and there was wide variation, increasing costs and wide variation. The data in this chart is looking specifically at the larger DRG hospitals in Oregon. It's 2017 data, and looking specifically at inpatient and outpatient services and the range in payment levels. And on the inpatient side, we saw payments ranging from 185% to 340% of Medicare. On the outpatient side, the range was in the neighborhood of 215% to 375% of Medicare. And there is no discernible difference in value or patient experience, quality, no correlation with any of that, just simply wide variation in payment levels without clear rationale as to what was driving that. So through the process of looking at where our cost drivers were and the need to ensure that we had sustainable health benefits costs, Senate Bill 1067 was introduced in the legislature in 2017. This was a pretty large bill. It was an omnibus bill. It included a number of different provisions, included a section related to state employee health benefit cost management, and two very specific provisions included in the bill impacted the OIB and PEP programs. And they kind of go hand in hand in this legislation. The first was the legislation placed a 3.4% limit on annual cost and premium growth for both programs. So year over year cost growth, we are held to a firm statutory requirement that our costs can only go up 3.4% on an annual basis and no more. And along with that, the bill placed limits on what insurers and third-party administrators that contract with our programs can pay for inpatient and outpatient hospital services. And as Mark mentioned, that limit specified in the legislation is 200% of Medicare for in-network hospitals and 185% of Medicare for non-network hospitals. And so very specifically, and this is one of those areas where I think, there are different models for how states and entities are approaching this. The legislation in Oregon places the prohibition on insurers and TPAs that contract with the state benefit programs, in that those contracted payers are limited in what they can pay those providers. Now, why benchmark to Medicare? And I think this kind of touches on some of what Marilyn talked about in her previous slides. But again, It's established reasonably transparent methodology that is broadly familiar. In addition, the annual rate of growth is generally lower and somewhat more predictable than commercial market growth rates. And looking at the data on this slide, and I think this is something we manage to in our programs, but historically, in general, like Medicare inpatient prospective payment rate updates annually remain within that 3.4% cap that we have on our annual cost growth. So that if our costs are increasing or growing in line with what those annual Medicare rate factors are, that we are more likely to meet our 3.4% statutory limitation on our annual growth. Another thing I think just to note from the perspective of a program implementing a reference price cap, there are a variety of conversations around this. There are proposed models to say use an average commercial rate for the region as the reference price, or some other sort of commercial benchmark to establish what that reference price is. And I think from the perspective of having to implement this as a state program, being able to benchmark to Medicare provides a certain efficiency and takes some of the debate off the table in terms of exactly how to calculate that reference price. The calculation is out there. The methodology is transparent. We are just relying on it and developing that multiplier in terms of setting the reference price for the rates. So there are a lot of factors to consider when thinking about Medicare, and some limitations to be mindful of, which I'll get to in a couple of slides. So a little bit more information about specifically what the statutory language that established our hospital cap indicates. It applies to hospital services only, so not the professional fees, but it does apply to all inpatient and outpatient services and supplies. The legislation specifically included language indicating that hospitals that are paid under the statutory cap may not balance bill. It also, there's nothing in the legislation that prohibits alternative approaches to payment methodologies, value-based methods, or anything like that. Those are certainly permissible, does not require fee-for-service payment. The statute also specifies certain hospitals that are exempt. And as was mentioned previously, we have 62 community hospitals in Oregon. 23 of them fall under this payment cap. They are the large DRG hospitals. The small rural facilities are not capped. They are exempt from the statutory provision. And the statute also does not apply to hospitals out of state. One of the concerns we had around limiting what our carriers could pay is that any prohibition on balance billing that was implemented by the legislature would not be enforceable on out-of-state facilities. So different considerations there in terms of, again, the approach and what the potential impact on members could be. What we currently have in place applies to in-state hospitals and prohibits balance billing. We do know, about 70% of all of our inpatient and outpatient services are happening in these capped hospitals. So certainly, we have utilization that's happening in those exempt hospitals that aren't capped. We have employees that live out of state with remote work and have or live say in a border area. Portland Metro, major population center in Oregon, is where I live, and I myself am just a couple miles from the state line with Washington. So there's certainly a lot of care that is happening for our members who live in Oregon or work in Oregon, but maybe receiving care out of state, and that also is not subject to the cap. In terms of implementation, we did undertake an agency rulemaking process to describe implementation requirements. And through our rulemaking process, it's a public process. We have rules advisory committees, public hearing related to those rules and regulatory provisions. And so it was the legislation passed in 2017 and took effect in late 2019 for the educators pool. That group has a plan year start date of October 1. So took effect in October 1 of 2019. And for the Public Employees Benefit Board, which has a January 1 plan year, took effect January 1, 2020. So in that period of time from 2017 to 2019, we were working on a lot of this rulemaking, implementation, working with our contracted health plans and TPAs on the specifics of implementation. They were having to go out and renegotiate their contracts with providers to make sure that the contracts were in compliance with these statutory requirements. And so it took some time and effort to get all of that into place. So it was good that we had that sort of 2-year runway to get things off the ground. In our rules, we do specify some additional requirements. CMS designated children's hospitals were exempted. They're not paid under IPPS. There's only a couple of them in the state. And we, for a variety of reasons, made the decision that the specifics of the payment provisions didn't apply to those facilities. We also, and this gets at the lesson to be mindful of, that Medicare is not always the best pricer or the best price benchmark for services that, say, are very common in commercial populations, but perhaps less common for Medicare enrollees. And an example we ran into was maternity and newborns. Those services, Medicare rates tend to, and especially double the 200% of Medicare rate threshold, tends to be far, far higher than commercially negotiated rates in the community. If you think about it, any Medicare enrollees that are receiving maternity services are probably pretty high risk and complex, and and infrequent. So those DRG rates, I would caution to be mindful about how you approach those types of services and in terms of a Medicare reference price. What we identified as the solution was our requirement that while the ceiling is 200% of Medicare, the maximum rate, that our carriers and TPAs are required to pay an actual rate that is at the lesser of bill charges, their negotiated contracted rates for the services, or the statutory cap. And what that has really meant for us is that on those services, we are generally paying the commercially negotiated typical rates in the community for the network, which are well below 200% of Medicare. Additionally, in our rules, we specify that carriers and TPAs must refund to OEB and PEB any overpayments identified if the total aggregate annual payment to a hospital exceeds twice Medicare. And this is, I'll do a little sidebar here and talk about how we manage compliance. And this is an area that is evolving for us. So every year we do a compliance verification review. And the way that is currently set up, we look for each carrier at the hospital level, and at each hospital ensure that the mix of services that was provided to our members in that hospital in aggregate is paid at no more than twice what Medicare would pay for that mix of services. So we are looking at each individual health plan and TPA and at each individual hospital. But when we do that compliance review, we're looking at sort of the aggregate for that hospital, for that insurer. And when we implemented back in 2019, we knew a lot less. This was newer. How to approach compliance? How burdensome would it be? Auditing every single claim can be very expensive every year. So trying to figure out how do we structure this in a way to ensure integrity while being manageable. I think since in the 6 years since, we've learned a lot, and we are currently reevaluating exactly how we approach compliance. I think I would say at minimum, on a compliance framework, you should be looking at outpatient and inpatient payments separately, because those tend to be at different levels of Medicare in a lot of cases. And then, additionally, I think at this point, in order to do the compliance verification, we do essentially reprice every claim and look at the claim level to get that aggregate total. So I think potentially there is the option to, figure out if doing an annual claim level compliance review is within scope. We're currently re-examining how we approach our annual compliance review, and I anticipate within the next year or so we'll be making some updates to ensure that it's right-sized, ensure that we are being sufficiently granular without being overly burdensome in terms of what is manageable on an annual basis. So, hopefully I can report back sometime in the near future with more detail there. In terms of our initial savings, our actuaries estimated savings of over 160 million during the first 2 years. They were concentrated on the outpatient side. That was higher at baseline, so averaged about 285% of Medicare at baseline versus the 235 on the inpatient. In year one, we actually did not have any savings on the inpatient side, and that was largely due to maternity and newborns, and kind of speaks to the situation I spoke about on the previous slide in terms of wanting to ensure that you are looking at sort of a lesser of arrangement on the reimbursement for services where Medicare is not a good benchmark. Subsequently, in year two, we revised our approach, revised our administrative rules, and that problem was addressed. And so our savings in the second year were significantly higher. In terms of the impact, so to date, really our carriers and TPAs have maintained the networks alongside capped payments. We didn't really experience member disruption due to this. I will say this went into effect right, late 2019, early 2020, and then pretty soon after that, with the COVID pandemic occurring, there were a lot of disruptions to services, care delivery, challenges for hospitals. So when we look at our data, we do see, a real drop in utilization in 2020 and 2021, and then a subsequent rebound in 22, 23. So it's the data. That situation has made the data, I think, a little perhaps messier than we would like. But when we try to control for or look at those different other factors that were occurring, we don't observe any member disruption related to this. We don't have hospitals turning members away. In fact, I would say most of our members, I doubt, even realize that this is a thing. They when they go in for services, they just think about what's my cost sharing, what's my co-payment, or what's my co-insurance. They're not thinking in detail about what is the specific contract between the insurer and the hospital say. I do think, and I don't want to steal Roz's thunder, but she has done some analysis looking at this, and has found, I think, to the degree that our members are enrolled in plans that have co-insurance, which some of our plans do, those members have actually recognized out-of-pocket savings. Having this cap in place, as I mentioned, has moderated our hospital cost increases. Those are generally occurring in line with Medicare annual increases. And I say generally because at this point, our outpatient payments are really getting close to that 200% of Medicare ceiling. Our inpatient payments are averaging about 170% of Medicare as of 2024. So one thing we're being very mindful of is the fact that there's room theoretically for those payments to still increase more than Medicare, but stay under 200%. And so that is something we're watching very closely year to year and work with our TPAs on. This data, 2024, is the most recent I have available. This is just kind of a snapshot of where our payments are landing relative to Medicare. We've got 3 different health plans we work with for 2 different programs. So you see 5 bars for every category, which makes it a lot to take in. But when you look at the hospitals on the inpatient side that are subject to 1067 and the outpatient side subject to 1067, you can see we kind of top out at 176% of Medicare on the inpatient side. And then on the outpatient side, all of them are hovering pretty close to 200% of Medicare. I do want to flag just, on the exempt hospitals, there's a lot of considerations here. Those, because they tend to be the smaller rural and critical access hospitals, Medicare pays them differently. They're not paid under IPPS. So the percent of Medicare that you see for those is not necessarily the same as a percent of Medicare you would see on a DRG hospital. Additionally, and there's some notes kind of on the slide. I won't read them aloud, but each of our health plans has a different geographic service area. So in some cases, a health plan is providing more care happening out of state, or perhaps more care happening in really rural parts of the state, which would explain why, we do see differences between the plans on those exempt hospital percentages, and some of that has to do with where those plans are located and providing care, and the specifics of the benefit plan design as well, because not all of them have the same cost sharing and plan design arrangement. In terms of considerations, I think payment cap adoption and approach is, certainly an opportunity to achieve not only cost savings, but more sustainable and predictable cost trends in the future. There are local considerations that, not every model will work everywhere, and not all of them will look the same, but things like considering that ceiling level. Where are you setting that reference price? Exempt providers, are there any exempt providers? And if so, how do you define them? And then what services and market segments are included? I think it's also important, and I've referenced this before, Medicare is a broadly familiar and transparent price benchmark, but there are considerations when you're using Medicare as a reference point for commercial plans. Noted that it may not price services infrequently used by Medicare enrollees with the best precision. And also just to note that at times CMS may grant retroactive rate adjustments to hospitals, and that can complicate commercial plan administration. And we've seen this a couple of times in Oregon with hospitals that have received increases for whatever reason, for different reasons from CMS, and CMS has provided that as a retroactive rate adjustment. And based on how the contracts are written, if the carrier is paying based on a percentage of what Medicare would pay, we're looking in a commercial environment of then having to go back and reprocess claims because that dollar amount has changed, even though the percentage of what Medicare pays has remained the same. And then I think it's also really important to be mindful of the potential impacts on provider behavior. Any sort of a reference price could influence some providers to seek increases beyond current payment levels. We certainly saw that in Oregon. Hospitals initially, they have services that are sort of all over the map in terms of the percent of Medicare that those services are at. And we certainly saw an inclination for hospitals to try to achieve 200% of Medicare on every single service, wanting to be paid at that ceiling rate across the board. So certainly work to do there to manage that dynamic. I also think, reference pricing can influence perspective on value-based payments and transition away from fee-for-service. In Oregon, we've heard, and I think, there are a variety of reasons that go into this, but the appetite to make the investment to transition away from fee for service perhaps changes for providers when they're thinking about that, in the context of a payment cap or limit. And then there are also potential impacts on utilization patterns. In Oregon, we have not seen significant, we haven't seen issues with members not being able to access care. We haven't seen, utilization increases that are tied to the payment cap at these hospitals. We have tried to do some work to look at, our capped hospitals, trying to doing things to shift services to different settings, say a smaller hospital within the health system that is uncapped, or an ambulatory surgical center. We're not seeing any clear indication of that. I think a lot of those small rural hospitals are located far enough away from the capped hospitals that, even if it was the same health system, like conceptually trying to transfer care there is not feasible. And, I also think, we are seeing more services being directed to like ambulatory surgical outpatient settings, which is actually a good thing because the payment rates on those from a dollar for dollar perspective are lower. And so if we can get, services shifted to outpatient settings with good quality and lower cost, that's a good thing. Even if it means, it's going from a capped hospital outpatient to an ASC, that's not a bad move to see happening. So yeah, I just, I think these sorts of dynamics also just kind of vary by community, geography, market. And then this is just a list of the hospitals that are capped. As you can see, a lot of them are located within larger health systems, and generally concentrated in some of the more urban parts of the state. And that is all I have in terms of, slides, but I'm grateful to turn it back over to Mark and then look forward to questions.
Thank you, Margaret, so much. And on the issue of questions, please, we see some coming up now in the chat. Please feel free to add your questions to those lists. And as Chris said, we'll get to as many of them as we can. It seems perfect to sort of close the formal presentation part of this program with the perspectives of an analyst who looks at a lot of numbers and a lot of trends and has done some path-breaking research and studies, as Margaret said, on what's been happening in Oregon. So, Roz, please.
Yeah, thank you so much, Mark. I really appreciate the introduction, and thank you for having me. It's great to be on a panel with both Marilyn and Margaret. So as mentioned, my name is Roz Murray. I'm an assistant professor at Brown University in the School of Public Health, and my research is really focused on hospital pricing and state efforts to improve healthcare affordability. And today I'm going to share some of the work that we've done for Vermont to inform the state's reference-based pricing effort. But before I do, I think it's worth just taking a quick step back and emphasize, the issue that reference-based pricing's attempting to solve or trying to solve here. These numbers here are national data, but essentially what you can see is from the late 90s to today, commercial prices have really diverged from the payments that Medicare pays hospitals for the same services. So back in the 90s, commercial insurers were paying close to Medicare rates, around 110% of Medicare. And now in 2022, which is the most recent data available, prices are more than 2.5 times what Medicare pays. So, we've heard both Marilyn and Margaret speak to this, but Medicare rates are really designed to cover the cost of care, accounting for things like patient complexity, local area wages, and other aspects, which I'll get into a little more later. But in this figure, it might not seem that Medicare prices are increasing, but they actually do, in fact, keep pace with inflation. And there's evidence that efficient hospitals can actually operate sustainably at Medicare's payment levels. So when commercial insurers, and by extension, employers and workers are paying, over 2.5 times that amount. It means they're covering, far more than the actual cost of care. So I think it's worth talking a little bit about what some of the assumptions are about what might be driving rising hospital prices. One common argument that is made by hospitals is that Medicare and Medicaid payments are too low, and they don't fully cover the cost of providing care to patients. So hospitals say they have to charge commercial insurers higher prices to make up for the difference. So if that were true, when we look at the data, what we'd expect to see is that hospitals that treat the largest share of Medicare, Medicaid, and uninsured patients would have the highest commercial prices, since those are the hospitals that would be, most in need of offsetting losses from the lower paying or non-paying patients. But this doesn't actually bear out in the data. So in this figure, it's showing the relationship between hospital prices relative to Medicare payments and the share of patients covered by Medicare or Medicaid or are uninsured. And it's pretty clear here that prices don't consistently rise as the proportion of non-private patients increases. And I'll also note that this is well supported by the economics literature. There have been a lot of studies examining cost shifting. So, for example, studies looking at, what happens to commercial prices when Medicare payments are cut. A lot of those studies are finding that commercial prices tend to follow Medicare payments rather than operate in the opposite direction. There's a large body of work here, and we even studied cost shifting in Oregon and found no evidence of cost shifting due to the price caps. So, generally, cost shifting doesn't occur on a larger, widespread scale. Now, another common argument is that higher prices reflect higher quality care. So we're, paying more because hospitals deliver better care or achieve better patient outcomes. But when we look at the relationship between quality and prices, there similarly, doesn't seem to be an apparent relationship. So here, prices relative to Medicare are rated based on CMS star rating, which is essentially a composite measure of hospital quality and patient experiences, and 5 stars is the highest rating. And what you can see if you look at the 5-star prices within the highest rating of 5 stars, there are some hospitals that are being paid more than 4 times what Medicare pays, but there are also some hospitals, some very high quality hospitals that are paid close to Medicare rates. And this distribution is similar across all of the different quality categories. And again, the economics literature rejects this theory, finding that there's really no clear connection between hospital prices and quality of care, especially in markets with limited competition. Now, the third argument is that, hospital prices are a result of hospital market power and consolidation. So as hospitals merge and acquire physician practices, they gain bargaining leverage to increase prices in negotiations with insurers. So when we do look at the relationship between prices relative to Medicare and hospital market share, there's an obvious positive correlation. Hospital prices increase by 1 percentage point for every 10 percentage point increase in market share. And again, this is well supported by the economics literature, which has found that hospital prices can increase from anywhere between 3 to 65% following a hospital merger. So, essentially high and rising commercial hospital prices are primarily driven by market consolidation or market power of hospitals rather than by higher costs or higher quality of care. Now, across the US, commercial prices paid to hospitals vary widely, even for the same services. There's a large geographic variation in prices relative to Medicare, and this type of variation is really difficult to explain just by differences in quality, costs, or patient needs. Instead, it's really another indicator that provider market power really does play a role here. Hospitals and health systems with greater negotiating leverage over insurers are able to command significantly higher prices. So when you look at commercial hospital prices relative to what Medicare pays, we see that Vermont is the 14th highest. This is based on data from the RAND Hospital Price Transparency Study, which is from 2022. So the state has some of the more generous payments from commercial payers, according to this work, which was conducted by my colleague, Christopher Whaley. Even within Vermont, there's a lot of price variation. Generally, we see that the critical access hospitals, those that are shaded light green, have lower prices relative to Medicare. But then the PPS hospitals in Vermont are averaging prices around 300%. And again, this is based on data from 2022. So these relative prices are likely higher today. So just kind of sharing an example of where a price cap could be set. So considering a price cap at 250% of Medicare, essentially this cap would target the hospitals, generally the PPS hospitals in the state. So there are still hospitals in Vermont that, on average, would not be subject to the price ceiling. So we did some work for the state to model potential savings under a 250% cap. And this would be applied to all commercial lives within the state of Vermont. And we estimated that Vermonters could save about $278 million annually from a cap at 250% applied to all commercial lives. And these savings would be passed along to Vermonters through lower premiums, deductibles, coinsurance. There are, opportunities potentially to make benefits more generous, pass along savings through wage increases. Those are the potential ways in which, patients ideally would benefit from a policy like this. We also modeled savings under alternative price caps. And you can see here that lower caps, so set at 200% of Medicare, for example, would generate even more savings, while higher caps at 400% would reduce the savings opportunity pretty significantly. This would be, fewer services would be subject to the price ceiling at a much higher cap. And also, we would certainly want to be careful about the potential opportunity of prices kind of creeping towards the ceiling, and that is not modeled or accounted for in these savings estimates. Now, I think my co-panelists have done a really great job of emphasizing why Medicare payments are useful benchmark in many cases. They're transparent, they're based on formulas that have been developed and refined over time. They really are intended to estimate, what it costs hospitals to treat patients, and they do allow efficient hospitals to break even. But I think it's important to emphasize that in reference-based pricing, the goal is not to pay Medicare rates. It's to set an upper payment limit that benchmarks to something that is actually estimating, underlying costs. So just want to emphasize a couple benefits to using Medicare payments. It's a comparable yardstick that employers can use across the country. The method is empirically based and transparent, of course, and allows hospitals, at least efficient hospitals, to cover their costs. But setting a cap that's at 250% of Medicare would allow hospitals to still cover their costs and generate a margin on their commercial patients. Now, I'm just going to do a quick overview of how Medicare's payments are determined, particularly for inpatient facility fees. Essentially, Medicare starts with the national operating and capital rate for the year, which in 2023 was around, the operating rate was around $6,000 and the capital rate around $500. Then these amounts are adjusted by geographic factors, mainly by the wage index to account for local labor costs. And then next, the payment rates are geographically adjusted are adjusted for case mix. So this is really based on, the patient's diagnosis. And then this is how you get to the base payment rate. So it's really it varies across hospitals, primarily based on specifically geographic factors. But in addition to this, there are some hospital-specific policy adjustments. There are additional adjustments for teaching hospitals, hospitals that service low-income patients. Rural hospitals also have an opportunity to get additional payments from Medicare. And then the case is also adjusted based on the stay itself. So if it's transferred to another hospital, there's an adjustment down to the payment. There's also increases in payment based on, if the case is a high cost case. So accounting for all of these various factors is really how Medicare determines the final payment that is made for a particular patient case, and all of these factors are accounted for in the benchmarking. So in work that we conducted for the Green Mountain Care Board, we put together a report to examine how Medicare payments in Vermont compare to other states nationally. Again, we're just looking at inpatient payments here, and we're also trying to make the payments comparable. We're looking at a comparable standardized case, so a DRG weight of 1. So what we find is that the average payment for a standardized case in Vermont is around $9,396, which is the 9th highest in the US. And the payments have been broken out by the different components. So there's the base rate that I mentioned, and then different add-on components for hospitals that serve low-income patients, teaching hospitals, and rural hospitals. And it's probably a little hard to see here, just kind of small on the slide, but if you look at Vermont relative to the states surrounding it, you can see that the base rate is somewhat lower than the surrounding states. And what really is kind of putting Vermont towards the top relative to other states are the hospital-specific add-ons and adjustments that the hospitals are able to receive from Medicare. So there's a pretty big bar is the hospital-specific payment rate. That's for sole community hospitals, which are rurally isolated hospitals. So the add-ons really do, make a big portion of the final payment rate on average. Now, if we look at Vermont PPS hospitals and how they compare to their neighbors in Maine and New Hampshire, we can see that payments are pretty similar. They don't appear to be underpaid relative to their neighbors for a similar patient case. So again, across the Vermont hospitals, base rates really don't vary much. They vary again by local area labor costs. But when you account for the add-ons, the hospital-specific payments, there's a lot of variation that comes from these. So again, I mentioned the sole community hospital payment, the HSP rate is a big payment boost that a lot of the hospitals within the state receive. And there's some additional add-ons that the hospitals are able to receive as well from Medicare. So I'll just wrap up and emphasize, Medicare payments are they're intended to cover the costs for efficient hospitals. And the hospitals within the state of Vermont, as a rural state, are able to receive additional payments to help support the rural nature of the hospitals and their patient mix. And I just also want to emphasize, price caps are just upper limits. They don't dictate all of the payments that are made to hospitals. Rather, only the highest prices would be subject to the price caps. And there's a lot of room for negotiation between insurers and providers to occur below those price limits. But even if payments are subject to these caps, Vermont hospitals should still be able to cover their costs and even still generate a margin on patient care. That is it for my portion. I apologize for running very close to the end of the webinar, but very open to questions.
Very, thank you, Roz, and also, of course, Margaret and Marilyn. We've got some questions in the chat. Chris, how would you like to proceed?
Yeah. Well, let me just try to summarize. There's sort of two main questions, and thank you, first of all, the panel. I learned a lot this evening. Vermont is entertaining a reference-based pricing cap for all of our insured. In Oregon and Montana, and I believe in other states, they are the capped plans are for one sector, the public workers plans. So the questions that I want to pull out are related to that and whether we should be watching things that might be different. And I guess there's kind of a two-part question that I had and also showed up in the chat. Have we seen hospitals shift, say, okay, fine, in Oregon, we've got to pay you a capped payment for these plans. We're just going to increase rates over here. Have you seen that? And then more generally, what should we be watching? Are there concerns because the attempt in Vermont is to do this across the board?
Margaret and Marilyn, you've got direct practical experience in this regard. What do you see, or what are you seeing now, Margaret? And Marilyn, what did you see what Montana was doing?
Yeah, I mean, we have not seen evidence of that sort of a shift. I can tell you that coming out of the 2020 to 2023 sort of era, what we are hearing a lot from hospitals in the state relates to increasing labor costs, workforce challenges, increasing supply costs. So costs are going up. I mean, they that's what they indicate, but in terms of what their rate increases are and how they're actually passing those on, I mean, I think, we're in a period now where like health insurance rates aren't, the increases are higher than they were, say, 4 or 5 years ago. But we have not seen any evidence that, hospitals are based on the cap on Oregon public employees, that they're shifting that, to other groups or significantly increasing rates there. They do serve other employers and other commercial in the state. And so, I think there's certainly, I think still, competitive negotiations going on in that commercial space. But the issues that we hear related to, the challenges that hospitals cite broadly in the state aren't pointing to the cap. They're sort of pointing to more kind of global delivery system and workforce issues. So yeah, no, I mean, we haven't seen any evidence that they're shifting prices and in ways to try to account for that.
Thank you. Marilyn.
Yeah, thank you. That I've been asked that question quite a bit, and we monitored that because we were very concerned that we are operating on taxpayer funds, which then become employee funds too. And so we were very sensitive, and we did monitor that. We did not find it in Montana, even working with the carriers. What we did see happen is that the Montana Association of Counties and the Municipal Trust went to the same methods we did, and they followed with the same TPA we used, and they negotiated the contracts through the TPAs. We also saw employer groups go individually to hospitals to negotiate based on Medicare rates. So we did not see that in Montana. We monitored it very, very closely because we were concerned about that being the taxpayer dollars. I'm getting a lot of requests now we're seeing more and more of revenue cycle management come in, and we have, Optum and other large vendors in that space coming into revenue cycle management and using AI. We're also seeing a lot more ambient listening happening and goes right into the coders, and we're seeing a lot more of coding. So I'm getting a lot more questions on how could you implement reference-based pricing? Where would it fit into the new methods of revenue cycle management? And it's bringing to surface the discussion that maybe you do need a benchmark. Maybe you do need a way of monitoring it. So I'm seeing renewed interest in it by different parties. But no, we didn't see any shifting.
I'll just also
Yeah, please, Russ.
weigh in quickly. As mentioned, we've done a few evaluations of Oregon's policy, and in our primary evaluation, we did look at cost shifting. We wanted to see if that was occurring. So essentially, we looked at the prices at the targeted hospitals and then the non-targeted hospitals to see if prices were increasing at the 23 hospitals that are subject to the caps. We found no evidence of increases in prices for those hospitals. Oregon, at least in the first couple of years, there was no evidence of cost shifting. The other question I think you had was about the policy in Oregon and Montana applied to a subset of lives, the state employees, versus in Vermont, there's a interest in applying to the broader commercial market. And just someone expressed some concerns about what the impact financially could be on hospitals by expanding more broadly. Marilyn could probably speak to the break-even rates much better than I can, but I think on average nationally, the hospitals can break even at rates set at 150% of Medicare. And so if you're looking at a price cap that's at 250% of Medicare, that provides more than enough margin for hospitals to cover their costs and provide care to patients. I'll also just emphasize hospitals have many other expenses than patient care expenses, marketing expenses, consulting fees, sports teams, sponsorships, and so those are other areas that they could cut back on in terms of expenses before they choose to reduce staffing or employee compensation. A couple things just to highlight there.
And just to add on.
Yeah, I'm really glad you mentioned that, Roz, because I remember negotiating with one hospital, and of course, I dug into their Medicare cost reports and developed the break even so we could know what could you operate on. And I also looked at the 990s. And one hospital said they couldn't because of their community benefit expense. And in Montana, this is big. They paid 1.2 million for billboards. And is that community benefit or is it advertising? So I think it brings up some good dialogue. Excuse me, Margaret, for
Yeah, no, I was just going to concur with what Roz noted, and we watch closely where our actual payment levels are, and I think the fact that we're currently hovering at about 170% of Medicare on the inpatient shows that that there's when we talk about payment adequacy, I think that my perspective would be that a 200% of Medicare ceiling provides a lot of room for negotiating below that.
Well, if I could stretch, if I want to be respectful of time, but I'm so curious, maybe just one last question. Margaret, you referenced that part of the exempt class of hospitals were out of state. And that's a huge issue for us in Vermont. And I'm wondering was that a political thing? Is that a technical thing? Could you just describe it for us? And is there a way, could we solve that problem, or would you expect we would face the same challenge?
I would love to see someone take it forward and come up with creative solutions. In Oregon, the main concern around out of state hospitals was that they would not have to comply with Oregon law that prohibits balance billing. And so in the way the legislation is written in Oregon, hospitals get 200% of Medicare if they contract, 185% of Medicare if they stay out of network, but either way, they can't balance bill. And I think, the concern was that when you start to talk about out-of-state facilities, would there be an inclination not to contract and have that balance billing ability? We have some communities in the state, especially like as you get out into Eastern Oregon, where, Boise, Idaho is where they go for care. That's where it's accessible. Or is kind of out in south of, there are communities in Eastern Oregon where they cross the Columbia River, go into Washington to see providers because that's where the providers are located. So we really had to kind of think about those areas of the state where out-of-state providers are their closest providers, and that was really what drove that. We'll be curious to see how Vermont approaches it, and if maybe we can learn from you some approaches there.
Marilyn, I see you smiling. Why are you smiling?
Yeah, because in Montana, we don't have children's hospitals. We don't have burn centers. We don't have the things that our employees really need. And we were worried about that. So one of the things we did is that we do have hospitals that are part of systems that are in other states. Providence is a big one out of Washington. Billings Clinic is affiliated with hospitals in Denver for their care. So we found a lot of affiliated hospitals or hospitals that belonged within a system. And what we did there was we actually put in our summary plan description, and we put in those contracts that affiliated hospitals, we would pay PBME, and we made it up. It was procedure-based medical expense. And we defined it as the rate that was paid to the most geographically located service, the most similar type of hospitals. And we slowly developed rates that we pay for that. And we had a few cases where, and we had a RAP network, but that was a Cigna network. So we had the RAP network, but then we had the PBME with really affiliated hospitals is how we did it.
Thoughts on this subject?
Well, Mark, have we reached the end of our time here?
Yes, I believe we have.
I want to say thank you, everybody. This has just been fantastic. At some point, we had about 100 participants. We are going to post this on our website. Please visit vhc911.org. You can subscribe to our newsletter. They're very periodic, not sending you emails every day or two, but we are dedicated to reducing costs for healthcare in Vermont, and so appreciate our allies all across the country. There are many, many people looking at the same challenge in their own communities, and grateful to our coalition and everybody who joined us today. Thank you so much.
Thank you, folks. Take care.